I will now invite Charlotte to come to the stage.
Good morning, everyone. It's really nice to be here, as Glenys has said, for the second Ward Sister Team Leader and Charge Nurse Conference. I think last year I had just about taken up post, and it was all very new, so I've got a year now under my belt, and hopefully that will be reflected in some of the key messages in the keynote address. I will make a start. I want to talk to you today particularly about our roles as professionals, what it means to be a professional and what the term professionalism means. Also want to spend a few minutes talking with you around the changes that are happening at the NMC in relation to particularly revalidation and the code, and to then work through how that translates to practice for you in your roles as Ward Sisters, Charge Nurses and Team Leaders. If I don't say all three all of the time, please forgive me, because it's difficult to remember to say all the three titles, but they're all very important. So I want to then go on to and outline my expectations for you in those roles to ensure that our patients and our clients and families receive the care that we all aspire to deliver and which is person-centred. In Northern Ireland we have a vision for quality care, Quality 2020. I'm sure most of you will be at least aware of the document and maybe familiar with some of its key objectives. Its focus is very definitely on safety, effectiveness and on person-centred care. It requires us to show professional leadership in order to ensure that those three aims are met, and requires us to show clinical and professional practice at a very high level. So I want to begin by unpicking what it means, what the term professionalism means, and what is the difference between a clinical professional and a HSC manager. And many of you are both of those things joined together. I was recently at the NMC Roundtable event where the Right Honourable Stephen Darrell, who is the current Chairman of the Health Select Committee but also a previous Secretary for State for Health back in the 90s, who obviously has been heavily involved in the work with the regulators and improving their performance and reviewing how we regulate healthcare professionals per se. But he said that the difference between managers and professionals was that managers provide context, professionals provide care. And he also went on to deliver what I think are three important messages to hear in relation to professionalism. One is that the core relationship between the professional and the service user, in that relationship the professional has a key individual responsibility to ensure that that relationship works and works well. He also said that to be professional is always about looking for a better way to do things. Professionals have a responsibility to keep a record and an account of their own practice, but also to measure that practice against the best available evidence and always strive for new ways to work. And thirdly, he said that being a professional meant that we all had a collective responsibility to raise concerns about poor and unsafe practice. So being a professional means you're on a register, and it means if you're on a register you accept the responsibilities of being on that register. So put simply for me, that means that when you're in a room with a patient or a client, should that be in hospital or at home or in an outpatient setting, the patient is relying on you to do their very best for them. There's nobody else in the room, there's no manager, there's no inspector, there's no clipboard, there's just you and the patient. And that is where your role as a professional in ensuring that you provide that high level of care to the best available standard that you can becomes really important. And thirdly, as part of that, I believe that being a professional is about upholding the requirements of the code. So you must be willing to raise concerns about care of patients which you believe may be at risk or may be unsafe. And you must be willing to do that regardless of the outcome. You have a professional responsibility to do that. The code requires us to make people our first concern. That's the first heading in the code, is that people are our first concern. And that is why the work that the NMC are leading on revalidation becomes so important. Revalidation is the biggest single change that's happening in our healthcare regulation system. And it has come at a time post the Francis inquiry, and it is intended to ensure that we highlight concerns earlier in the process, and by doing so prevent harm. It does provide for us a regular opportunity to reflect on our practice at an individual level, but importantly to make sure that that fits in line with what the code requires us to do as being a registrant. The NMC are also reviewing that code this summer in order to make sure that it underpins the requirements of revalidation, and to ensure that we continue to have the right skills and the right standards in order to deliver person-centred care. Revalidation will require confirmation that the registrant says they are fit for practice. And you may be aware that the first stage consultation process in relation to revalidation closed at the end of March, and that the model going forward is based on appraisal and third-party sign-off. And there are lots of discussions about how ineffective appraisal would appear to be in certain parts of the system across the 4 UK countries, and a further debate about who the sign-off person should be. It seems to me imperative that if to get on the register you're required to be signed off by a registrant, to stay on the register you should also be signed off by a registrant, because only those registrants understand the requirements that you're required to meet under the code and under revalidation. In Northern Ireland then, over the next few months, myself and other senior nurses will be working to ensure that our position on that statement becomes very clear, that we would require a registrant to be the sign-off person so in order to re-enter somebody onto the register under revalidation. So moving forward with professionalism, revalidation and the review of the code, it is very clear to me that the ward sister, charge nurse and team leader role will have a key contribution to make. Whether that should be around ensuring a robust process for revalidation, at least ensuring effective appraisal, reflection and evidence of good standards of nursing and midwifery care. I said earlier that I would outline what that means for you in your role and try to articulate for you what the standard is that I expect of people who work as ward sisters, charge nurses and team leaders. I believe that you have an absolutely fundamental role in running our health services, and that role is about ensuring that patients and their families have good clinical outcomes and, where possible, a good experience of care. Recent reports, Francis, the RQI inspection into the Royal Victoria Hospital, the announcements made yesterday by the Minister in the Assembly in relation to the governance review, for me signify the importance and the crucial role that ward sisters, team leaders and charge nurses have. I want to refer to the work of Sue Pembry, who in the 1980s talked about the ward sister key to nursing. And although that is work of significant age at this point, I think the important messages are still the important messages. And Sue said that good nursing care doesn't just happen, it needs to be organised in a deliberate leadership and management function. And I believe that this statement couldn't be more true today. I expect ward sisters, charge nurses and team leaders would make this happen. Having the right staff and the right skills is the first step, but it means also determining rotas that ensure quality of care is provided, and ensuring the provision of mandatory training, learning and development and appraisal and supervision all take place. Further to that, I expect that care is devolved as close to the bedside as is possible, and that means a system where nurse allocation allows for continuity, responsibility and, most importantly, accountability. So we need to know who should have, who is or who will provide care to that patient. The information then needs to be recorded in the nursing notes. The second point that Pembry made was that ward sisters need to be able to exercise control, and she was talking specifically about ward sisters, but I think the principles apply right across the delivery of health and social care. So the second point was that ward sisters need to be able to exercise control and authority, and in order to coordinate individualised care, they need in today's language we would talk about person-centred care, so they need to be able to exercise control and authority in order to be able to do that. And I know that all of you have very complex roles and that you require lots of other people and lots of other services to help make that happen. However, my expectation is that you are in control and that you do have the authority to run your wards and departments. And I want you to take back that control and feel that you're in control. And make that absolutely clear to all. I know it and you know it, but the patients and their families, they need to know it too. The third point is that ward sisters need to act as a strong role model in practice. And I know that you all wear your uniforms with pride, and when you put it on, be under no illusion. People observe what you say, they see how you act, and they see how you behave. And in that provides huge opportunities to role model strong professional practice, expert person-centred care. I understand that you all have to work at a very high level with complex situations, strategy, operational delivery plans, etc. But this cannot be at the expense of every individual patient experience of the people in your care. You might think that that's a slightly negative approach or hard approach, and that I don't understand how difficult it is to be in your shoes and wearing your uniform and doing your job. But I have challenged myself about that. I have been a ward sister with very high standards, as I know you all do. Now I know that you're all saying that that was 100 years ago, and things are different. And you're right, things are different, and it wasn't 100 years ago, it was 15. But the important things haven't changed. The important things are the things that Sue Pembury talked about. They're still important today. The unique function of the nurse described by Virginia Henderson is the reason that you and I both came into nursing as a profession. That hasn't changed. It was the same in Florence Nightingale's day, and it's unlikely to change anytime soon. So I want to tell you 3 things that shaped my experience as a ward sister and how it helped me to move my ward forward to deliver more person-centred practice. They are small things, but they're about values and behaviours, and they're about role modelling strong professional practice. So the first of those is that I stood in my ward one day at mealtime observing nurses helping patients with me, and it was a Nightingale ward. I'll tell you how long it was. But at one end of the ward there was a senior staff nurse feeding a patient standing up with the cot sides up, feeding the patient, no communication. And at the other end of the ward there was a third-year management student, and she was sitting on the bed making eye contact with an elderly gentleman, helping him with his knee. Now I know you're all saying, well, there's the first mistake, because you can't sit in beds anymore. But actually there are ways around that, aren't there? There are ways about working with people at the same level and working in partnership, and there's something about the body language that says this is a partnership relationship, it's not me doing unto you. And that's the main message of that story. The nutritional element of that is important, but the main message is about how we work with people in a partnership approach. The second example is that I was on, as we used to do in the Royal, carry the bleep at the weekends for the directorate, and I was the sister on for that weekend, and I walked into my ward, and it was a Saturday afternoon, in the middle of the afternoon, and there were a number of patients who didn't have visitors. And I said to the nurse, I'd like you to go and speak to the patients because they have no visitors. And they said to me, but sister, we have to clean the drip stands. And I said to them, I don't really care about the drip stands today, I want you to go and talk to the patients. Mistake number 2, you have to clean the drip stands today. Because of infection control. But again, I think there are ways, creative ways that we can find to do both. You know, the use of housekeeper roles, etc., by allocating specific tasks to people, allow for both to happen. So the nursing auxiliary sort of looked at me a bit kind of, you know, funnily to say, well, okay, if you're the sister, we'll do what you want. So they went, they made conversation with the patients, they talked about sport, they read the paper, they engaged with the patients. Which is what I wanted them to do. But I think it sets a tone about the importance of what we do and when we do it and how we do it. And the third example is probably the one that I think is most powerful, and that's about the language that we use to describe our patients. So on one morning I was organising breaks, morning breaks, you know, 9:45, 10:15 sort of time. And the curtains were pulled around this gentleman who'd had a stroke. And I didn't disturb the curtains, but I did shout into the nursing auxiliary, Paul, are you ready to go for a break? And he he shouted back to me, "No sister, I'm finishing off this wash." At which point, you know when your stomach hits the floor and you feel that kind of sinking feeling, I thought, oh God, is that really how we're describing intimate care with patients? And is that how we view our patients? And I was about to be honest, I was about to give him a ticking off, and then I realised, well actually, I was the instigator of that conversation. I was the one that disturbed the care. I prioritised the break over that intimate care experience with the patient. So we had a conversation about that, and we began to change the language and how we described our care with patients. So those are non-high-tech examples. They don't take long to do, but they do send out a very clear message about the importance of how we treat people. And that, I think, is a fundamental and will continue to be a fundamental element of care and compassion. And for that, ward sisters, charge nurses and team leaders, you are accountable. And that is where the code, the work on revalidation and being a professional does make a difference. So in addition to organising care in a way that allows person-centred care to flourish, in addition to being in charge of your area and role modelling strong professional practice, I expect that you're available every day to talk to your patients and their clients, and your clients and their families. They should know who you are, and that you're there primarily to ensure that their best interests are at heart. I know you are, and you know you are, but again, the families need to know and they need to see that you are. And I would like you to consider and understand that that is a very fundamental expectation that I have of you in your roles. I expect to see the ward team or the district nursing team, or whichever team you're in charge of, displayed in a way that people know who the nurses are by name and who's caring for them. I expect that you don't have a mission statement, but that you do have principles of behaviour, and that they start with things like, we will always behave, we will never behave. Clear commitments and statements to the people that we care for. I expect that you're available to meet families, and perhaps for many of you working in the acute sector, you can think about ward sister surgeries, where you make yourself available on a daily basis or every other day basis for a short period of time, where patients and relatives know that for that period of time you're doing nothing else except making yourself available to them to hear their concerns and deal with it. These are big asks, I know, but I don't apologise for them. That is what is required, and that is what is expected. And I know too that you have expectations of me and the other senior nurses. And to that end, I think we have made a start with that. We have given you a regional job description, taking forward the work that many of you were involved with NIPEC, which allows you to promote and work in the way that I've described. You have a development pathway that ensures you have the skills and the necessary competencies to undertake those roles. And recently we have the Minister who made his announcement in January that he was supporting normative staffing in acute hospitals in medical and surgical wards. And as part of that work, ward sisters are 100% supervisory. I think the Minister has made his expectation clear and his support clear for you in that role. The next phase of that work has already begun, and it's rolling out to district nursing, health visiting and ED nursing for this year. So I think you've got clear commitments from the nurse leaders in Northern Ireland around your role, around your title, around your job description, around your skills and competencies, and now in relation to having the right staffing and the ability for you as leaders and managers to be available to do the job that we require of you. I don't think that that's going to happen overnight, and I know there will be a session later in taking you through some of the detail of that work. But there is a commitment, as resources become available in a very financially constrained environment, to make that happen. So in conclusion, the role of the ward sister, the charge nurse and team leaders is more crucial now than ever. The regulator, the Minister for Health, the profession, and most importantly, the people that we care for, value your role immensely. This is why there are such high expectations on you and for you. Robert Francis was very specific and forthright in his recommendation to strengthen your role. The Minister has made it his priority to deliver on that recommendation. We must all work really hard at continuous development of what I think is a very precious ward sister, team leader, charge nurse role, and in doing so have a direct impact on person-centred outcomes for patients at home and in hospital. I know that I have been a bit challenging to you today, but I hope that you also understand that I'm very supportive of your role. Nursing and midwifery is never and never has been afraid of challenge. Nursing and midwifery is challenge, and that's why we all came into this very, very valuable and important role.